To this COVID lecture series. My name is Greg Postma at the Medical College of Georgia, Augusta University. I'm here in the VA. Tuesdays we spend at the VA. Dr. Mike Yang from Shreveport is our current fellow from the Shreve. He'll be heading to San Antonio in a few months to do laryngology there. He is going to be on the chat function the entire time. And any questions come up, we'd really appreciate you just go ahead and type those out to Mike, and he'll feed them to me at the appropriate time. It's a lot simpler to answer questions as we go in case you want to go back and look at a slide or look at a video. So with that said, we'll go ahead and get started. The initial talk is going to be dysphagia evaluation. That may run into the transnasal esophagoscopy lecture, but time will tell. Disclosures, Cook Medical, Carolina Speech Services do consultation work for both those groups. Dysphagia is not a diagnosis. It is a symptom, a feeling of difficulty, discomfort, and swallowing. And as such, it requires an evaluation that actually leads to a diagnosis. It's very common, and it costs our nation a great deal of money, particularly, as we'll talk in a moment, with an aging population. In inpatients, particularly areas that have a large neurosurgical, head and neck, or neurologic services, it can be greater than 50% of our inpatient census can complain of dysphagia. And the impact is huge. It's much more beyond quality of life, but aspiration pneumonia adds significant costs and length of stay at our hospitals, and the cost of tube feedings, placement in rehab facilities, so on and so forth. And therefore, it's an important problem that requires us to figure out what's going on. In general, as just said, 20% of people over 50. We'll talk about aging more in a second. There's been two big studies looking at nursing homes by survey instruments, and about 60% people sniffing dysphagia. Parkinson's is an important population. We think about that mostly as voice issues, but it's not readily known by most. That's the leading cause of death in individuals with Parkinson's is aspiration pneumonia. And so we have a large Parkinson's center. We have a large Parkinson's center, and therefore we see a lot of people with dysphagia. Stroke, we say 80%, but the vast majority of these folks resolve their dysphagia spontaneously. And then once again, 100% head and neck cancer, that obviously isn't true for T1 tumors and so forth, but I put that there because of the fact that so many of our people, they get radiation or radiation with concurrent chemotherapy, end up with dysphagia at some point in their life. This is a great thing from the New York Times, which demonstrates the age of our population by decade. Makes it very visual, very easy to understand that not only is our population growing, but the percentage of individuals that are 65 and over continues to grow, and it is anticipated to be more than 20% of our population in another 10 years. Thank you to the New York Times. Maybe the only time you'll ever hear me say that. It's important to realize that there really is no magic bullet. Dysphagia is very often multifactorial. It takes a team approach, evaluation treatment. Otolaryngologists working along with our speech language pathologists particularly, but also our gastroenterologists, consultants, and neurologists. Dysphagia therapy the importance of this cannot be overstated. It is key that you work with a speech language pathology team that works with our patients so they learn not just various exercises to help them with swallowing, but compensatory and dietary changes when exercise and surgery is not enough. Surgery is needed when the more conservative types of care fail. And it's to our discredit that we've done a very poor job in research of the surgical therapy. I'm a fanatical golfer, so you're going to see golf slides periodically. This is at Kiowa after I put a ball in the water, scared a bird. In the literature, one looks at this And in general, when we look at what causes dysphagia, it's very much age and institutional related. The older you are, more likely you are to have cancer or neurologic issues. When you're young, much more likely to be infectious. And in most centers in middle-aged North America, certainly reflux plays a huge picture. Infectious diseases, this is a patient with AIDS, with rip roaring, with horrific candidiasis. So the causes are altered not just by age, but depending on referral patterns. We looked at our folks, 200 new patient visits for dysphagia, and ours was most commonly chemo and radiation therapy. A 100 patient survey out of UC Davis was gastroesophageal reflux, very much due to Peter Bolofsky's interest in reflux. A series out of Mayo Clinic not long ago demonstrated that almost 10% of their patients with dysphagia had documented eosinophilic esophagitis, reflecting a center of excellence they have to study that there. So there's a great deal of variability. So at our center, number one, radiation and chemotherapy, followed by reflux, cricopharyngeus muscle pathology that includes Zenker's and Killian-Jamison diverticula. Then, despite a comprehensive evaluation as far as a endoscopy, contrast study, and high-resolution manometry, the number fourth most common problem is unknown. We were unable to determine what was the cause. And then a smaller number, people with presbyosophagus, webs, ineffective esophageal motility, EOE, of course, and various central demyelinated neurologic diseases. Radiation chemotherapy, number one without a doubt at our center. And we see this, as you do, on a daily basis. Very, very hard to rehabilitate these people once they have lost their ability to swallow. That's why it's critical that you work with these people, that they're working with speech therapists and working with you on exercises, even when they're asymptomatic. It's important that exercises start early, keep things going. Aging dysphagia, it's kind of interesting that in general, you lose 1% of your skeletal muscle mass every year starting at age 25. It's also interesting that there's not been a single Olympic weightlifting record set by anyone over the age of 30. Sarcopenia, or loss of muscle mass with age, is a real problem, and it is reflected in our elderly people with dysphagia. Once again, tying into the importance of exercise with our speech language pathology team. So how do we approach these people? Well, history is pretty straightforward. Looking for various factors that we know can cause dysphagia. People have had neurologic diseases like stroke, post-intubation, trachs, trauma, radiation, so on and so forth. And also, what type of dysphagia they have: solid food versus liquid. Solid food, more likely a structural problem. Liquids make you lean a little more to neurologic and aging issues. Weight loss and pneumonia are critical. When you ask people, how bad is your dysphagia? If they say they can't eat and they haven't eaten for 6 months and they weigh 300 pounds and have no weight loss, you've got to kind of question that. Aspiration pneumonia, documented weight loss are huge red flags to us. Associated hoarseness, glottic closure helps with swallowing. It doesn't always help, but when people are hoarse, you need to obviously evaluate that, or looking for glottal insufficiency. Reflux, as I mentioned, our number two cause, the number one cause at UC Davis. And medications. A lot of medications, particularly in the elderly, lead to dryness and xerostomia, and this has a profound effect on swallowing. Kind of covered that right there. So as a surgeon, one of the first things we can do is a flexible examination of swallowing. And you're looking to see quickly and simply in the office how they can handle routine dietary challenges. We usually start with applesauce with a small amount of food coloring, and then depending on how they handle that, we may go to liquids or remarkably dry and tasteless graham crackers that we obtain here. We used to get these great cinnamon, really great cinnamon graham crackers, but they were so good that our residents and fellows ate most of them, and we didn't have any for our patients. So we've gone the complete opposite direction and got nearly inedible ones now. So if they can handle the applesauce and do with liquids, we'll then challenge them with chewing, and if they can get solids down. This is good. It gives us a chance to go ahead and look at glottic closure, associated lesions. We look down the airway. We can look for some small supraglottic or supraglottic or hypopharyngeal webs and scar tissue, and as well as see how they handle the challenge of the food. We're pretty aggressive. We give it to them really fast to see if they'll penetrate their larynx or if they'll aspirate there in the office. We do these usually without a speech language pathologist and done very, very quickly. One advantage the fees gives us over contrast studies is we can actually assess how a patient handles their own secretions. There's a robust degree of literature demonstrating that failure to handle your own secretions is maybe the single most common risk factor for aspiration pneumonia. Here you have an individual with significant vocal fold atrophy. You can note the vocal processes touching and a huge glottal gap, and lots of blue dye here in both piriform sinuses and a small degree of laryngeal penetration. Here's another patient undergoing the fees. This person had a normal modified barium swallow, did fine with applesauce, but then he throws down the graham cracker and right back at you. I hope you just had your breakfast and can enjoy this. One of my favorite slides. Love that, don't you? Back down the hatch. Come on, man. This person had a failure of relaxation, cricopharyngeus muscle, and responded very well to an endoscopic cricopharyngeal myotomy. Another patient, we often don't think enough about, we think about pharyngeal squeeze by having someone do a glissando like that and look at the pharynx, but we don't always think about sensation. Here's someone, everything's working except his entire pharynx and larynx is completely insensate. And one of my favorite videos. Down the hatch. I'm not a good enough video editor to put this on a loop. This is all in one setting. Isn't that great? With complete glottic closure and something like this, there's not a lot. There are some research using capsaicin and other, and as well as thermal therapy to improve this, but that's a tough thing to address. Vocal fold immobility with atrophy. And these people, in my experience, about 50% of individuals will improve their swallowing with improvements in glottic closure. The one thing you can give them, certainly, is improved quality of life and a stronger, close the door, nice. A stronger cough, which hopefully will protect them from aspiration pneumonia. And this can usually be easily done in the office. But we can make no promises to our patients. Once again, I say it's about a coin flip when you improve glottic closure in these patients. What do you think the likelihood that I could actually hit that tree with one drive? There's a fairway, a football field wide beyond it over the hill, but I managed to hit the tree. Contrast studies, these are important. As many of your universities, you get contrast studies, barium swallows and modified barium swallows sent to you that are of terrible quality. And I think it's important that although it frustrates us, adds to healthcare expense, and it really frustrates the patients, but if the study isn't adequate and give you the information you need, you have to repeat it. And that is very, very important. It's important that you look at the studies yourself. I'll be honest, I'd say Mike Yang has found as many hypopharyngeal and esophageal webs as any fellow in my history. It is remarkable how few of these are found by the radiologists. But when you look at these and go through these things carefully, you'll be astounded at the pathology you'll see that our radiologists who are in a great hurry are missing. But esophageal webs are not an infrequent problem for people with solid food dysphagia. And these folks respond readily to an aggressive dilation. I also mentioned here for diverticulum, we're not going to talk just about Zenkers or Killian-Jamisons, but you need to look at the relationship of any diverticula to the cricopharyngeus muscle. It is once again surprising how many diverticula are misdiagnosed. These can be traction diverticula after surgery or trauma, Zenkers, or Killian-Jamison diverticula. It's important you look yourself. We'll skip this. Well, we'll look at this for a second. You see this, and we're not going to sit there and pimp anyone here, but right here in the middle, you'll note that there is the cricopharyngeus muscle right there. Again, you see this, wow, that's obstructive. Look at that. It's darn near 3/4 of the lumen is obstructed during the swallow. This patient is entirely asymptomatic, however, and this was done just for fun. And cricopharyngeal bars, as they're called, are not always pathologic. And so you have to tie your x-ray study in with the patient's history. In fact, at least 50% of people over the age of 70 will have a cricopharyngeal indentation of at least 50% of the esophageal lumen. You also need to look at your own contrast studies, because you look here and you'll see some tertiary contractions in the distal esophagus, but there's a lot more going on here, as you'll note. This person has solid food dysphagia, and we're surgeons. We work up north in the GI tract, so we think a lot about the cricopharyngeus muscle, but it's important before you address the cricopharyngeus muscle by cutting it endoscopically or opening or Botox, is that sometimes they form a protective function. Look right here where it's actually stopping esophageal pharyngeal reflux, or actually regurgitation, as you'll see right here. Boom, right back up. This patient does indeed have solid food dysphagia, but imagine if you cut that muscle, would the patient be better, or would the patient begin to regurgitate after every meal? If the patient was to lean over, would they get to look at their lunch? And so it's important that you evaluate esophageal function before you go after the cricopharyngeus. Here's an individual, solid food dysphagia again. And you notice both an obstructing, very large hypertrophic cricopharyngeus as well as a hypopharyngeal web. This is another patient. This is an interesting patient. This, you'll notice the tiniest of webs right here in this individual. And now we have a endoscopic evaluation. The patient refused transnasal esophagoscopy, but this is the same patient that you see right here. This web was visible on only one single image of a barium swallow, yet here you'll note 1, 2, 3 separate independent webs just above the cricopharyngeus muscle. And there's the lumen of the esophagus. So this individual, we cut, and then did an aggressive, probably 90 or 100 French dilation to take care of this problem. We probably injected steroids there as well. Transnasal esophagoscopy is going to be the second lecture, but it is a significant part of our evaluation of patients, particularly those with solid food dysphagia. This is an individual with pill-induced dysphagia, leading to a small stricture in the mid-esophagus. Why do TNE? Well, first of all, we've already mentioned reflux is common, and maybe a third of the patients in North America. It's very, very common due to our diet, the degree of obesity in our nation. Extraesophageal reflux, depending on how to define it, it may be a third of patients, maybe far less. It probably is far less. It's important, we think, to look at the esophagus. When every single published study has shown a minimum of 50% of the patients have esophageal pathology. And remember, this isn't a GI clinic. These aren't GI articles we're talking about. These are otolaryngology articles that 50% or more of patients have with complaints that lead them to an otolaryngologist have esophageal pathology. This can be dysphagia, chronic cough, so on and so forth. We'll talk later. There's a lot of applications in head and neck oncology, mainly ability to biopsy and dilate. We'll talk about Barrett's a little later. Lots of fun clinic procedures. We use channeled scopes now for everything in the office. We use them to inject. We use them to drop guide wires for dilation. We use them to spray local anesthetic in the airway, and we use them to deliver lasers to various locations. And this has absolutely revolutionized laryngology in the office. It's also important to note that T&E, when compared to conventional sedated esophagoscopy, is vastly safer and less expensive. And plus, it's fun. I've had it done 5 times, and it's usually a good time for most of the people involved. Most people are shocked at how easily tolerated it is. Some notes about this is that if you remove neurologic disease from the equation, almost 3/4 of adults with dysphagia will have something in their esophagus contributing or being the prime etiology of their dysphagia. And then another thing that's really, really important, there's unpublished literature out of Wisconsin, the group in Madison, and that has demonstrated that almost 40% of their patients with documented pathology of the distal esophagus point above the clavicles as being the center or the origin, if you will, of their symptoms. Previous reported numbers were maybe up to 30%, but the most recent stuff, once again, presented, not yet published, demonstrates that more than 1/3 of their patients point above the clavicles. Once again, emphasizing that if you're not looking in the esophagus, whether or not you're looking with your eye, whether or not you're doing a contrast study, or referring to a gastroenterologist, you're missing things and you're not doing your patients the kind of service that you can provide. If you're uncertain about patients with dysphagia that you'll look through, 2 things to think about: eosinophilic esophagitis, we'll talk about later more. We talk about T&E, and remember these high webs that are easily missed on contrast studies. The GI literature, when they do screening esophagoscopies and esophagoscopy with dilations in people with dysphagia, 20% of the time they'll find no pathology, or excuse me, that's not true though. When they find no pathology and do an empiric dilation, 20% of those people improve their symptoms, which suggests that those are the people that have these small webs that we're missing on contrast studies. This patient, I don't know if this is video or this is, you can see here the trachealization, slight narrowing, and the white papules that suggest eosinophilic esophagitis, diagnosed depending on where you're at, more than 15, more than 20, more than 25 eosinophils for high-powered field, depending on where you're at. But a key cause of solid food dysphagia in adults, and also not uncommon to find people that have reflux complaints that are not responding to anti-reflux therapy. They'll sometimes have EOE. Barrett's esophagus is a person with Barrett's esophagus up to the aortic arch with no dysphagia and no heartburn, only chronic cough. And another chronic cough patient with Barrett's. Why is this important? It's not just important to look in there for reflux changes, but esophageal adenocarcinoma is the #1 increasing cancer in Western Europe and North America. This is old data here, but more recent data is unchanged. No one is entirely certain why this is, but it is vital, I think, in our patients that we look for this. 7 to 9% of ENT patients have Barrett's esophagus, and with a 50 to 100% increased likelihood of developing cancer here, we need to look in this area. Solid food dysphagia always has a cause. It's just up to us to hunt it down. I think T&E is a key diagnostic test, particularly if patients had a history of head and neck cancer. The ability to biopsy, once again, in the office without going to the operating room, is a huge safety feature and time saver for patients. Par 3, number 16 at Cypress Point. That is a par 3. I donated a ball into the ocean here, as you might have imagined. Manometry. High resolution manometry has really changed in the last 10 or 15 years, everything we thought about the esophagus. The physiology, the pathology of the esophagus has been amazingly changed, and we're beginning to do this in the pharynx. Groups out of Wisconsin, Dr. Ashley O'Rourke, the Medical University of South Carolina, folks in New Zealand, Australia are working hard to take the science that we've learned in the esophageal body and to take that high-resolution manometry and take it into the pharynx and even up to the velum. It's a nice way of looking and documenting the strength of pharyngeal contraction, vice estimating it on a contrast study or with the pharyngeal squeeze maneuver. For me, it's a great way of looking at whether or not the cricopharyngeus is coordinated with the swallow, is it relaxing completely, and is a large cricopharyngeal bar actually stiffening or not. Sometimes you do these, they relax completely with the swallow versus those that are hypertonic or don't relax with the swallow. Manometry can give you that data. It's an objective means of looking at esophageal motility, and in fact can be graded now using the Chicago 3 classification that the gastroenterology community has developed. Whether or not it's improving patient outcomes is hard to say objectively. In my experience of doing manometry for probably the last 15, 16 years, is that I'm doing less surgery, but my outcomes appear to be better. Evolution of manometry, we'll skip this, I think, and go, well, some of this is kind of important. This is kind of neat, right? If you look at this on the left side of the screen, this is an old school manometry waveform of 3 sensors, but middle of the pharynx, tongue base, hypopharynx, squeeze, at the same moment, the cricopharyngeus relax, and you notice the trough of UES relaxation. Patient on the right has essentially a dead pharynx with normal UES relaxation. You can see this right here. This patient would do better with strengthening the pharynx with conservative exercising because there's nothing to dilate or weaken in the area of the UES. It already relaxes completely, therefore wouldn't benefit from surgery. Here's a patient completely different. Once again, manometric catheter in place. Both pharyngeal sensors are demonstrating essentially a dead pharynx, but a complete failure relaxation at the cricopharyngeus muscle. This patient was treated with swallowing exercises to begin to get the pharynx stronger, along at the time probably electrical stimulation, and also a couple weeks after that underwent surgery on the cricopharyngeus muscle so that it could relax to allow a weak pharynx to push some food down into the esophagus. HRM have 36 different rings, each of which has 12 different pressure sensors. And it's very intuitive. If you look at this, the intensive contraction is seen here on the left, the wintry cool colors are lower pressures, the red hot summer colors are higher pressures. You notice the upper esophageal sphincter, the lower esophageal sphincter, and the esophageal body. As the UES relaxes, almost in complete synchrony, the LES will open as well, and then you see the impression of a peristaltic wave. We're not going to go a lot into interpretation or anything like this, but these are divided into contractile elements, which are then analyzed using the high-resolution manometry software. These are the segments, S1, S2, S3, and the transition zone, the area between smooth skeletal and smooth muscle, where we often see food getting hung up, particularly if the transition zone corresponds to the arch of the aorta. A normal swallow. And now we are able to add impedance, the purple, which we usually use for the actual bolus, a saltwater solution, is shown here. So see muscle contraction with the actual bolus being propelled down into the stomach. Here's an individual with, we call bolus loss. So the bolus, since time is going along the x-axis, the bolus stops here, and you see the bolus stuck in the upper esophagus, in contrast to this going into the stomach. So impedance has even broadened our knowledge of esophageal motility and disorders of the esophagogastric junction. Right now, there's an international working group in working on using this same technology up on the CP muscle. If you got a friend that can burp, you can get these good pictures. There's the U-shaped cricopharyngeus muscle in the post-cricoid region. But manometry plays a significant role in what's going on in the pharynx. This is a great article some years ago by Leeper and Dysphagia Journal, demonstrating different types of cricopharyngeus muscle abnormalities. Here's a normal sized muscle. You can imagine stretching this or injecting Botox in this may be of benefit. How about this cricopharyngeus muscle? Look at the difference. This patient has massive hypertrophy in the muscle here. Stretching this might help, might not. Botox would simply make this an atonic muscle, which would simply obstruct the lumen. Something like this definitely favors endoscopic or external myotomy. We think that may explain why some of our patients that we used to give Botox to actually didn't get better, but often got worse. Here's an example of a patient. Remember we said the area of the upper esophageal sphincter, and this is magnified. This should be blue during a swallow, but you notice bright red colors. This is called increased intrabolus pressure. And then after dilation, the patient undergoes HRM again. We don't do this routinely, but if patients agree to this, it's kind of fun. Complete resolution and now normal intrabolus pressure once the cricopharyngeus has been dilated. This is one of my favorite patients. This patient was sent for an endoscopic cricopharyngeal myotomy because he had solid food dysphagia and pointed above his clavicle. And he had maybe a small bar on a contrast swallow. But look here, pretty much normal at the upper esophageal sphincter, but significant distal esophageal spasm. This patient responded to nifedipine, a calcium channel blocker. He certainly didn't need a myotomy. Imagine a myotomy with someone with this degree of spasm, and he'd probably be regurgitating all over you. Each of these sections is 5 seconds. That is a long amount of spasm with nearly every swallow. A group, and this has been studied by the Mayo Clinic in Florida, as well, I think a couple other centers as well, but they were the first to publish the utility of high resolution manometry in people with chronic dysphagia after anterior cervical disc surgery. And we're now using this as well. If you undergo manometry, and if the pressures are entirely normal in where the plate is present, then the removal of the plate will probably be of little benefit. In this patient, however, when you have increased bolus pressure at the location of the plate, then removal of this is probably indicated. And that's where you use here, and some other centers are as well, as an indication to remove a plate, providing they've healed from their neurologic surgery. One of our favorite operations in people with decent esophageal function and cricopharyngeus abnormalities is the endoscopic CP myotomy. And we have a nice little view here. The way we like to do it, we leave it open. We don't suture, use fiber and glue. We go to high power. Now we ablate. At this time, we simply cut. Now we use a circle and go back and forth and ablate a large portion of muscle. But we always check with a 30-degree or 0-degree scope to make sure there's absolutely no muscle fibers present right there. The pharyngobasilar fascia completely intact through here. And I like this for a couple reasons. It stayed in focus, which is always good when you're making a video. But probably more importantly, this patient presented a day and a half later with mediastinitis. And so despite what looks like a well-performed study, you can still get complications with these patients. So in general, what we do with these folks is a team approach whenever possible. We don't do it in the same office, in the same room at the same time, but people, particularly people with any kind of complex dysphagia, require a team approach, a focused history, and in the office, a quick FEES exam is often helpful. Now during the COVID time, getting contrast swallows has become even more difficult to get, but we usually had open slots on my clinic days in which we had arrangements that individuals could go and get same day barium swallows and occasionally modified barium swallows. That's not always easy to do, but I'd encourage folks that have an interest in dysphagia to make those kind of arrangements with your radiologist to improve your ability to perform one same day shopping, if you will. Solid food dysphagia, more likely to lead us to do a transnasal esophagoscopy or a barium swallow, while neurologic history or dysphagia to liquids, more likely to head down the path of a modified barium swallow with one of our speech language pathologists. It's also important to note with that is we always get an esophageal screen. When we are at meetings with our speech language pathology colleagues, we're always kind of disheartened when we ask folks in the audience, and it's usually at least 30 to 40% of the attendees, their hospitals don't do esophageal screens. But this is important. It's not a full-fledged barium swallow, but it will demonstrate significant distal strictures, tumors, achalasia, so forth. And I think it's important that a quick esophageal screen be part of a modified barium swallow. If the issue is still, or the diagnosis is still elusive, manometry, I think, is absolutely critical in these patients nowadays. You got specific diagnostic tests, hopefully will lead to one or two key diagnoses that you can then treat. Out in Arizona, a beautiful little par 3, and a lot of people hitting the cactus right there. Mike, we got any questions?
We do. We have two. So one is about the perceived sensitivity detecting penetration and aspiration using green dye in liquids in an office fees.
Repeat that. I'm not sure I understand what you're getting.
So essentially, how sensitive do you think when doing in-office fees?
Gotcha. It's a good question. It's actually been studied, and it depends a lot on the, should we say, the aggressiveness of the examiner, the length of time one takes. In general, in the speech language pathology literature, the suggestion is a fees is more sensitive to aspiration, particularly small degrees of trace aspiration, than a contrast study. And there'll be articles showing pictures, or at least presentations. They'll have simultaneous modified barium swallow with a fees, and they'll show visible contrast agent with green food coloring or whatever below the cords, and you still can't see it on the contrast study. But if you do a fees and you take 35 seconds to do it, you could very well miss degrees of aspiration. Probably the key population you'd see that, it would be Parkinson's patients and the elderly, because if you do a quick fees, and quite frankly, I do them quickly, is you're not going to be able to test them when they're in the fatigue state. A Parkinson patient at the end of the day, trying to get through a long meal, is going to be worn out. They're going to be fatigued. If you see them and they'll probably be aspirating. You see that same patient at 8:45 in the morning and do a fees for a minute or so, or 2 minutes, they're not fatigued, and you may not be sensitive enough to pick that up unless you have a prolonged examination.
A couple more questions. One was about basically which scopes we like to use, whether that be the weirdo or the slimline when we're doing CP myotomy.
Yeah, that's it. I like the wordoscope. You can jab the tip right at the base of the cricopharyngeus muscle, even without the presence of a diverticulum, and really distend this area. So the wordoscope is our number one. The second would be the Storz, S-T-O-R-Z, Storz Slimline scope. It's a wonderful thin scope that if you can't get the Werda in there and expose the cricopharyngeus muscle, this will. And in fact, sometimes we use that for Zenkers. You can laser through it, and you can use different types of electrosurgical instruments through it. You are unable to put a stapler through it, however, at this point. Probably the best thing to look at would be Mike Pittman wrote an article on laryngoscope several years ago with great photographs and diagrams demonstrating that technique. And so I think it was in laryngoscope. But I'd encourage you to look at that article to get great idea of the technique.
Okay, I was asked to come closer to the mic. So last question that we have so far is basically how long it takes to do an HRM, if it's something that we'll do frequently in office in addition to T&E.
Yeah, once again, it's a great question. My HRM machine actually began to smoke a couple of years ago, and we lost it. And since our GI department has 3 or 4, University would not get me another one, although allegedly I'm getting one this year. We'll see. So doing them once again as a one-stop shopping is fantastic. a quick call to the insurance folks. Virtually everyone approves it in a matter of moments, and you can do it. It does not take long at all. In fact, it takes less time than a modified barium swallow would do. You decongest the nostril, the more patent side. The catheter is, I believe, 3.9 or 4.0 millimeters in an external diameter, which means it's equal or smaller than your average distal chip flexible laryngoscope. You pass it with water and sips of water with a straw, and it usually passes readily. You look at the pressure waves as you insert it, and then you tape it to the nose. You give the patient a little bit of time, a couple of minutes to acclimatize to it, so they're not swallowing on the catheter, and then depending on if you're doing HRM or HRM with impedance, will determine how many swallows. The average, the small limited protocol is only 10 single swallows. You can't double swallow during this. And so with impedance, depending on what's going on the protocol, 15 or 20 swallows, you're done. You pull the catheter out, and you can literally do the analysis that same day if you desire. Usually you do a handful, then do them all at once. But it's quick, it's easy, and not infrequently, you can make the diagnosis during the examination because of very obvious pressure waves, whether it be everything being very weak, like patient with ineffective esophageal motility, or someone with distal esophageal spasm or something like that. It's a great aid that I think is invaluable if you are seeing patients with dysphagia. Let's talk a little about the future as far as treatment's concerned. I'm checking the time here. Let's see what we got here. Okay, thanks. I think regenerative medicine, and this is, I threw this in here because we have almost all residents. So when you're looking at things to sink your teeth into over the years, certainly stem cells and regenerative medicine gets all the headlines, and it's super exciting things. There's work already going on, the injection of myoblasts into tongue and pharyngeal musculature following radiation therapy, not somewhat analogous to the use of myoblast into into the myocardium in patients with viral cardiomyopathies. There's some work going on in Japan looking at the addition of growth factors with stem cells. Stacy Hallam's looking at neurotrophic factors to be added into this. Imagine if you can inject these kind of things into a weak cricopharyngeus or a weak tongue. Different types of novel delivery systems, including hollow walled glass microspheres. Paul Weinberger's working on some, but there's a lot of stuff going on in stem cells in people with dysphagia. Groups in Spain and in the UK, I think one study in the United States, looking at transcranial magnetic stimulation, primarily in people that have neurogenic problems post-stroke, and some in Parkinson's, based on the concept of neuroplasticity, essentially relearning how to swallow, and doing this with and without conventional swallowing therapy. We studied, it's quite an attractive picture, we studied along with the group at UC Davis. We wanted to work out a model for profound oropharyngeal dysphagia, which you see here, and then find out if certain types of more aggressive surgery would be of benefit. And so one of the big questions we wanted to look at was whether or not laryngotracheal separation, an operation we used to do, and it's still done in some centers, was better or not when compared to doing a narrow field laryngectomy in people with profound oropharyngeal dysphagia, the folks that are basically getting 2 or 3 pneumonias a year, and they're going to die if you don't do something to change that. So we went ahead and studied this in the ovine model. This is control, noting both, you noticed aspiration here and some going down the esophagus. Then we went ahead and performed near laryngotracheal separations, which you see here, in which the blind pouch essentially still fills with contrast, although a lot more does go down the esophagus. We then compared this to near total laryngectomies, and we did this by measuring the amount that came through the esophagus and the amount, more importantly, that stayed in the upper airway, and demonstrated that the laryngectomy appeared to be vastly superior. So several centers have stopped doing laryngotracheal separations and just are now going to just do a narrow field laryngectomy. We think because the importance of laryngeal elevation and the pulling forward of the larynx and cricoid off the pharynx is so, or in the proximal esophagus is so important, that having it lay there is a physical barrier to swallowing, and therefore the actual removal of it results in a much more efficient swallow and a better quality of life. This is the other area that hasn't been studied. Really aggressive heroic surgery for people with profound dysphagia. This patient undergoing a bilateral laryngoplasty, laryngohyal suspension of the mandible, cricopharyngeal myotomy, and a neurorrhaphy of the superior laryngeal nerve to the great auricular nerve. And we had a panel that discussed this at the last ELS meeting in England. And the bottom line is a bunch of folks are doing these intermittently in people with severe and profound aspiration, but the ELS is hoping to put together an international consortium that everyone will have the same endpoints, everyone will agree on what type of heroic surgery will be done, so we can actually determine who actually benefits from this. Is it just a surgical exercise, or are there patients that are going to benefit from this rather than just doing total laryngectomies? A little shout out, Dr. Rebecca Howe at Cincinnati has started, it's been going on for almost 2 years now, an international study prospectively looking at the treatment of cervical diverticula. And I would encourage residents that are at centers that aren't in the study yet to go ahead and see if some of your faculty involved in this. There are currently 13 centers. They're American, New Zealand, and one in the UK that are currently in this study, and over 180 patients have currently been prospectively enrolled in this. Dr. Howe can email you the entire IRB consent forms, everything, then you just cut and paste into your own center's IRB forms, and we'd love to have more and more people involved in the first ever prospective cervical diverticulum study. Other thing from people that are interested in laryngology and dysphagia in general is the Dysphagia Surgical Society meets twice a year. Clearly, we didn't meet this year in Atlanta, but if you're interested, please email me about this. Fall Voice, we do hope it takes place. COVID will help determine that, but it's not till October. Hope to see a lot of you there. Here's my email. Love to hear from people. Those that are interested in the Zenker study, let me know. People that want information about the Dysphagia Surgical Society or just have any dysphagia questions, feel free to email. And I love seeing videos, contrast studies, and talking to you about your patients. Oh, got to do this. This is my favorite patient. Some of you have already seen this, I suppose. Patient with globus sensation and no dysphagia, police officer in Georgia. The resident went ahead and went down to the GE junction you see in the distance, and we found this giant mass in this patient's esophagus. So the resident went down the GE junction. I took it over to retract it out of the esophagus, trying to find where this large mass was based at. This is a transnasal esophagoscopy, so anterior is to the bottom of the screen. Keep coming out. Basically looking at peristalsis on this mass, trying to find where it's pedunculated. Is it got a little stalk? Is it broad-based? And right when you get near the cricopharyngeus muscle, the patient a little more sensitive, there are gags. Now I'm looking at the TV monitor, and the resident is still looking at the patient, and she just suddenly goes, "Dear God." And this is what we saw. And he had completely regurgitated this thing. And we palpated it and stuff. And the guy goes, "Doc, what do you want me to do with this?" And he basically just gulped down and swallowed the whole thing back down. It ended up being a 26 centimeter leiomyoma that was based at the proximal esophagus. So that will, you've seen something good post-breakfast. You hopefully try to remember that during lunch in a little while. That's near where I live. That's looking at the 18th hole here in Augusta, Georgia. Not the real Augusta National, just our little club. How about another question or two, and then we'll transition over. Mike, any questions there?
Yeah, so we have a question about how commonly T&E is performed by a laryngologist.
Gosh, it depends.
And then why it's not more widespread, you think?
Became kind of exciting about 16, 18 years ago. And a lot of places, we used to have courses. We literally had one course, more than 100 participants, and they're all hands-on. So we had the various companies providing all kinds of scopes, sterilization equipment. And like I said, our top course had 110 people at it, I think 109, 110 people actually practicing on one another with this. When we got our first scope back in, 20 years ago, the fellow and I flipped a coin. I lost. And so I got to be the first person done in North Carolina. I was at Wake Forest, and he scoped me. And then he wouldn't let me scope him. That wasn't very fair of him, but nonetheless, that's what happened. But there are places it's super common. There's places that it's not. I think, and I'll explain in this next lecture why I think that T&E should be commonly performed by otolaryngologists, not simply laryngologists, but all otolaryngologists. I think it's a huge thing, as you'll see in a moment, particularly head and neck oncology. And we'll go through this, and I think your question will get answered. What's the other question, Mike?
That's it.
All right, well, let's go ahead then. And we have some more videos. So we've got an extra 10 minutes here to talk about transnasal esophagoscopy itself. This was a few weeks ago. I was at Mount Sinai as a visiting professor, literally days before things got shut down for COVID. And this was where I was golfing down here in South Carolina, just across the border, a couple of days going up there. And so I sent this up there our thoughts are with the people up there in New York now. We hope we can get back to some degree of normality, particularly up in New York, Chicago, San Francisco, and Seattle. We've got it pretty easy in Augusta right now. In Atlanta as well, things are getting tough, but our prayers and thoughts are with you folks up there. So T&E, we were the first folks that did this stuff. We got to remember Chevalier Jackson, kind of like the god of bronchoesophagology. He was one of us. He was an ENT surgeon.
Can't see you.